Welcome to Crack Surgery. Today we are going to discuss appendicitis, the most common acute surgical emergency. Appendicitis is an inflammation of appendix that develops most common in adolescents and young adults. Appendicitis is an acute inflammation of appendix and it the most common cause for acute and severe abdominal pain. Abdomen is most tender at McBurney's point, which is 2/3 and 1/3 at the spinal umbilical line. This corresponds to the location of the base of the appendix. Common causes of appendicitis is fecus impaction, a layered build-up of calcium salts and fecal debris around the piece of fecal material within the lumen of appendix. Second cause is lymphoid hyperplasia. The appendix contains lymphoid tissue that can become inflamed as a result of infection or inflammatory bowel disease, that is IBD. Third is parasite. Uncommon causes are tumor, foreign materials. A wide variety of foreign objects can be lodged in the lumen of appendix, trauma, intestinal worms, lymphadenitis. Acute appendicitis. There are types of appendicitis. First is acute appendicitis. Acute appendicitis, as its name implies, develops very fast, usually in a span of several days or hours. It is easier to detect and require prompt medical treatment, that is surgery. Acute appendicitis occurs when the vermiform appendix is completely obstructed either because of bacterial infection, feces, or other type of blockage. Infection may also cause swelling of lymph node, which then adds pressure on the appendix and cutting of its blood supply. Appendicitis can be chronic, but it's a rare condition. Chronic appendicitis is an inflammation that can last for a long time. This is rare, according to the report of published in Therapeutic Advance in Gastroenterology. It occurs only 1.5% of recorded acute appendicitis cases. Basically, chronic appendicitis means that the appendiceal lumen is only partially obstructed, causing inflammation. The inflammation worsens over the time, causing internal pressure to build up. Stump appendicitis, a rare appendicectomy side effect. In most instances of appendicitis, appendectomy is a usual procedure recommended, and it works by completely taking off appendix to prevent it from rupturing. If the appendix has already ruptured, additionally, treatment measures are performed during the appendectomy as the infection needs to be prevented from spreading. Symptoms of appendicitis. First is pain. Initially, periumbilical region, then pain is shifted to right iliac fossa, parietal peritoneum irritated and inflamed, which cause severe pain in right iliac fossa. Anorexia is always present, which follows by nausea, vomiting. Clinical signs in appendicitis. First is pyrexia, low grade fever after the 6 hour, tenderness localized to right iliac fossa, muscle gardening due to the pain, rebound tenderness, also known as a Blumberg sign, tachycardia, which suggests perforation, gangrene, or peritonitis. Signs to be elicited in appendicitis are Rosing sign, Psoas sign, actuator sign, Dunphy sign. Any movement or coughing cause pain in right iliac fossa. McBurney's point, that is tenderness. McBurney's point tenderness. First sign is Rosing sign. As we see in the video, palpating in the left lower quadrant cause pain in the right lower quadrant. Second sign is obturator sign. Internal rotation of the hip joint causing the pain, suggesting possibility of inflamed appendix located in the pelvis. Rosenstein sign. Increased pain in the right iliac region as a person is being examined lies on his or her left side. Next sign is Dunphy sign. Increased pain in the right lower quadrant with coughing or any abdominal pressure. Iliopsoas sign. Extending the right hip causing the pain along the posterior lateral back and hip, suggesting retrocecal appendicitis. Pathology and pathogenesis. Appendix lumen is obstructed, leads to congestion within the appendix, inflammatory exudate and mucus, increased luminal pressure. Initial stage might resolve in some patient. Appendix may be distended with mucus, which is known as mucocele. There are further complications of appendicitis. First, gangrenous appendix. Thrombosis of appendiceal artery or vein leads to gangrene of appendix. Most common cause is perforation. The complication rates are 58%. Perforation rate increase at both ends of age spectrum. Periappendiceal abscess, the most frequent complication, periappendiceal fibrinous adhesions. Next is peritonitis. Bacterial peritonitis in absence of fibrinous adhesion. E. coli is most common organism. Next is bowel obstruction due to the inflammation. Septic seeding of mesenteric vessel. Infection along the mesenteric portal venous system. Phlebitis, pilot thrombosis, and hepatic abscess. Obstruction. Mucus and inflammatory exudate increase the intraluminal pressure, which obstructing the lymphatic drainage. Further, edema and mucus ulceration plus bacterial translocation to the submucosa leads to venous obstruction, cause of further distension of appendix, which can lead into ischemia of appendix, then bacterial invasion and acute appendicitis occur. Perforation: if the fever is more than 102 Fahrenheit and WBC raised more than 18,000, if ischemia continues, necrosis of appendicular valve happen and gangrenous appendicitis appear. Perforation with free bacterial contamination of peritoneal cavity. Now we can see here there is incidentally there is a site of perforation of appendix. This is a gangrenous appendix because it appendicular artery is an end artery. Phlegmonous mass or paracecal abscess, greater omentum and loop of small bowel become adhered to the inflamed appendix, and walling of the spread of peritoneal contamination leads to phlegmonous mass or paracecal abscess. This is a natural procedure to prevent spreading of inflammation. This destructive phlegmonous appendicitis after adrenaline and appendectomy. Alvarado scoring system in the appendicitis is symptoms, signs and lab tests. We can migration of pain is value is 1, anorexia 1, nausea or vomiting 1, right lower quadrant tenderness that is 2, rebound tenderness is 1, elevated temperature is 1, leukocytosis is 2, and shift to the left is 1. Total point is 10. If the score is 7 to 10, strongly predictive of appendicitis. If score is 5 to 6, is equivocal, radiological investigation must be done. If 1 to 4, appendicitis must rule out. Investigation: TLC is raised 10,000 to 18,000 and neutrophil count is more than 75%. If TLC is more than 18,000, there is a suspected perforation. Abdominal plain X-ray, standing X-ray should be done. Abdominal ultrasonography should be done, and CT scan for the perforation. Treatment: absolute bed rest and NBM, IV fluid supplement, analgesic should be given, and proper antibiotic should be given. Then appendectomy within 24 hours as soon as possible should be done to prevent perforation. Indication of appendectomy is acute appendicitis, recurrent appendicitis, mucosal of appendix and C of appendix. This is the incision of appendectomy. Most common incision is McBurney's incision, which is parallel to the spinal umbilical line at McBurney's point, which is 2/3 from medial and 1/3 from lateral. Second incision, which is also known as crease incision, just oblique to it, and one horizontal incision known as Rocky Davis incision, we can extend to medial side known as Fowler-Weiss extension, and which can extend to lateral side. This extension is known as Rutherford-Morrison extension. Complication of appendectomy: most common complication of appendectomy is wound infection. Second is intra-abdominal abscess. Third is ileus. Fourth is respiratory complication like pneumonia. Fifth is portal pyemia. Sixth is adhesion intestinal obstruction. Seventh is fecal fistula. Eighth is rupture hernia. Third and last is DVT and embolism. Presentation of appendicular lump: usually on third day of acute attack of appendicitis, we can feel lump in right iliac fossa, and due to the tenderness there is a gardening over the lump. Fever with increased pulse can we notice appendicular lump. Should we operate? No, don't operate, because severe adhesion and difficult to separate the part, bloody and dangerous to operate, risk of fecal fistula, risk of iatrogenic injury during the surgery. Ochsner syringe regimen: first mark of size of swelling for further assessment. NPO and IV fluid supplement, antibiotic, analgesic should be given. Temperature and pulse and fluid should be recorded, and allow oral liquid after several days. If more vomiting, then an antiemetic with PPI should be given. If size of lump decreases, continue the same treatment. After 6 to 8 weeks of interval, appendectomy should be done. Prognosis: the 90% of success rate for this regimen. Failure to this regimen, suspect the Crohn or CA of appendix. Criteria for stoppage of conservative treatment, that is rising pulse rate, rising the temperature, increasing or spreading abdominal pain, increasing size of mass, vomiting. Thank you for watching the video. If you like the video, please like my video and subscribe my channel. Thank you, and hit the bell icon to stay updated. Thank you.